Next one is Bruce Bray. Where are you, Bruce? There you are. So Bruce has been our director of respiratory at Emory Hospital for a long time. Has also been one of our best teachers for respiratory care. Is going to help lead our mechanical ventilation breakout session again tomorrow. But now he's going to talk about weaning from mechanical ventilation, because Bruce has worked on this for a long time and has some good opinions about how we might do this better. So,
good morning. We're going to talk about something other than sepsis for a few minutes. But mechanical ventilation, also I'm going to focus on adult weaning and not pediatric, because as we know, most of the time pediatric patients are so much more durable than adults, and a lot of times what we ventilate adult patients for, there's no need to do that with pediatrics. And so I'm going to focus mainly on the adults today. I think we'll go right into this. Okay. First of all, mechanical ventilation, and I did a lot of research and looking through a lot of references dating back all the way into the 90s up until present. And so I've got about 25 years worth of information here. Mechanical ventilation is a life-supporting modality, and most patients are extubated quite readily. And so that's the ones we're going to focus on today, not those that have a lot of multiple disorders and things like that, and that are on a ventilator for more than a few days. So most patients are about 20% will fail on their first attempt. So we have about 80%. And a lot of the data, and you'll see it later on, between 70 and 90%, you'll see that quite a bit. But basically, only 20% fail in their first attempt. And these basically are patients that are coming off the ventilator fairly quickly. However, we do spend about 40% of the duration of that mechanical ventilation on trying to wean them towards extubation. And that's what we'll kind of concentrate on. But before that, just go over a brief review of there are tons of modes on the ventilators now. And it's just amazing how many that they have. However, we have the traditional modes, which are still there, that have been around since the 1960s and 70s. And that's assist control, SIMV, pressure control ventilation, APRV that was developed by Dr. Downs and Christine Stocks down at the University of Florida. And then we have some of the newer modes, and I'll focus mainly on ASV and pressure regulated volume control. PRVC was probably the first hybrid mode that was out there, and it's developed by Siemens, which is now McKay, of being able to target a tidal volume and let the pressure be regulated in order to reach that targeted tidal volume as opposed to a tidal volume set. In the last few years, there really hasn't been a lot of new innovation as far as newer modes and all that, as opposed to just tweaking some of the current hybrid modes that are out there. So just a brief review on assist control. At Emory Hospital up the street, we call it synchronous control mechanical ventilation, but assist control and SCMV are basically the same. And one of the characteristics of it is the control factor. That's the good and the bad of it. It controls your tidal volume. It controls your rate. If the patient wants to breathe anymore, they can assist, but they're going to get the exact same tidal volume. And so you have a set flow rate, you have a set flow pattern. So some of the pros are, it does offer full ventilatory support and full control, except if the patient assist, and that can cause some problems sometimes. But because of all of the volume, all of the settings being controlled by the operator, it is a good ARDS friendly ventilator. It's ventilation mode. And as far as using the ARDSNet protocol, it's very easy to follow that protocol in the assist control mode. However, on the other side, on the flip side, there isn't a lot of variability here. All the patient can do is add to the rate. Everything else is pretty much fixed in time. And so when I teach, I tell people it's kind of like you're taking a snapshot as opposed to a video. Once you set it, it stays that way until you come back and change those settings. Now, SIMV came along, in the mid 70s, and it was supposed to be the panacea. It was supposed to be the greatest mode ever made. However, and one of the rationale behind that is that it allowed for the patient to breathe spontaneously in between mechanical breaths. And so you would have a particular rate for the patient. Anything above that, the patient could breathe spontaneously. A few years later came out press support, and that was supposed to be a really novel idea at the time. And press support basically worked that you either had a small level of press support to just offset the work of breathing. You could use higher levels of press support to augment spontaneous tidal volumes and also decrease the work of breathing. And then Neil McIntyre came out with a press support max where you would ventilate the patient, and I'm embarrassed to even say this, give them 12 to 15 cc's per kilogram of body weight, which is a huge tidal volume that we thought was good back then. However, the strategy was to decrease the SIMV rate to allow the patient to increase the spontaneous rate, to increase the spontaneous rate and volume. And so as respiratory therapists, a lot of times we became knob turners, to where we would start them out on a rate of 12, go down to 10 to 8, and it showed that using that mentality actually slowed down the time to wean on a patient, because you would put them down on a rate, you'd get a blood gas, you'd wait a couple hours, you'd put them down at more rate, and then finally you would get down to a rate of 2, and some of the ventilators even came out with a crazy rate of 1 breath every 2 minutes. And so weaning time was actually slowed down with SIMV, and it wasn't what we hoped it to be. So the pros, again, guarantees a certain number of breaths. Mandatory breaths are synchronized. And when we came with a synchronization mode, again, we thought that was a really good thing, and it did. It decreased the patient ventilator asynchrony, but in where you would have a timing window for the patient to either assist and then get a mechanical breath, or if it went out of the timing window, the ventilator would go ahead and breathe for them. However, it did show that there was an increased imposed work of breathing, tendency to reduce cardiac output, venous return, and then it also prolonged ventilator dependency, which was caught on this reference. We go to the newer modes, and I'm just going to talk about adaptive support very quickly. One of the novel things about it is that the tidal volume was looked at as ideal body weight. And this was a real novel idea of basing volumes on ideal body weight as opposed to just looking at the patient and setting up a volume. And I'll have to admit that I did that for many, many years. I'd look at a patient and I said, okay, that's an 800 cc tidal volume. Not really realizing of the barotrauma and the volutrauma that we were causing to these patients. But ASV basically, it sets the rate, the IE ratio, expiratory and inspiratory time, and it's basically doing 200 calculations per second. And so it's doing a mini pulmonary function test on the patient and coming up with the best strategy to breathe for that patient. So all the tidal volumes from the ventilator are in a pressure control nature targeted for tidal volume, and the spontaneous breaths are pressure support targeted for tidal volume. And so as the ventilator, basically as the patient starts to breathe more, then the ventilator backs off. And so there's no dysynchrony or asynchrony here, because if the patient assists the breath, it automatically becomes a spontaneous breath with a volume target. If they wait an appropriate amount of time, the ventilator will give them a pressure control targeted for tidal volume breath. And this was based on the minimal work of breathing concept developed by Dr. Otis back in the 1950s. Basically what Dr. Otis did is looked at a lot of different animals, and humans included, and looked and see where their most effective breathing pattern was. And so it looks at the resistive and elastic components of the lung, and basically comes up with the best rate and the best tidal volume for that particular patient. Now, there's also some newer techniques that we have that have been out for a number of years, and that's proportional assist ventilation and NAVA, or neurally adjusted ventilatory assist. And there have been a lot of studies about both of them, and they have shown to decrease the patient ventilator asynchrony. And so we're ventilating patients in a kinder way now, and that's a good thing. And so PAV allows for distributing the work percentage. The ventilator does X amount, the patient does X amount, and you can adjust it anywhere from about 10% up to about 95%. And that has shown to decrease the work of breathing on the patient, but it doesn't really show that it moves them to extubation any quicker, because but it does provide safer ventilation. And NAVA, which is an amazing technique, but it's a very expensive technique because you have to buy an esophageal catheter that has a little chip down at the bottom, and you have to sink that catheter in the patient's esophagus, and it fires off the diaphragm. And so not only does it trigger faster, but it also is more appropriate. The more that the diaphragm basically gives out electrical energy, the more, the stronger the tidal volume will be. And so it's very proportional to the electrical activity of the diaphragm, and it is shown to also decrease the work of breathing. And so, but we look at all of these new modes that we have out there, and you know, I grew up on the MA1, and now we're using ventilators that are basically computers that happen to breathe for people. The first ventilators I used, they had a lot of moving parts. In fact, one of the ones that we used for a long time was the Emerson ventilator, and I'm dating myself here, and a lot of the young faces I see out there have probably never heard of an Emerson, but the Emerson ventilator was developed by John Emerson up in Massachusetts, and it was basically built from hardware parts. The humidifier was a Presto pressure cooker. The bacteriostatic filter was a copper mesh. It used a gas meter that you have on your house to measure volumes. I mean, it was really quite a contraption, but for a long time, that's what we used. And so these newer ventilators, they give the operator the opportunity to ventilate the patient safely. And so it gives you information like how many cc's per kilogram of body weight that you're delivering to the patient, so that you can be safe on that. However, the craziness is that all ventilators still have like up to a 2,000 cc tidal volume you can deliver if you want to. And it just is beyond me to why do you keep having those types of parameters or types of settings that you can do on a ventilator when we know that they are dangerous. I don't know of any human being that needs a 2,000 cc tidal volume, but is still on the ventilators. And so the ventilators do have a lot of features to where they can use lung protective strategies, but it is up to the operator to utilize those and to monitor the patient effectively. Or you can be into that same where we're given 10, 12, 15 cc's per kilogram of body weight, because those settings can be done. But with the newer ventilators and the monitoring, we can provide a safer environment. And so the newer modes can incorporate lung protective strategies, but in all of the articles I've read and talking with other people, other respiratory therapists and physicians and nurses at other institutions, they haven't really seen to where that moves them towards extubation, because you get to a certain point to where you've got to say, you know, it's either time to sink or swim. And so there's not really a way that just you can go all the way from a particular mode and then just magically extubate the patient. And so none of them have really shown any kind of superiority to that over a sedation vacation or withholding some of the medications to let the patient kind of wake up, so to speak, doing a daily weaning assessment or a screening, and doing a standard breathing trial. And so we had 2 large multi-center studies that demonstrated that mechanical ventilation can be discontinued abruptly in approximately 75% of the patients. Remember a while ago, that number was 80%. So in this particular study, it was very close. It was only 5% different. Also, several studies have showed that a direct method of assessing readiness to maintain spontaneous breathing is simply to initiate a trial of unassisted breathing. In other words, you get to a point, say, okay, I've assessed the patient looks like they can do it, let's do it. So, protocol-driven practice, and that's what is really important, what I read a lot of places, is that doing it a standard way, doing it the same way every day, and that everybody is on board with doing it that way. And so it has to be a team effort here. And so evidence-based practice now supports early attempts at weaning in a protocol-driven fashion. So here we are again, that 70 to 80% of patients who require mechanical ventilation, they can be extubated after a trial of spontaneous breathing once the process has been created. In other words, when we ventilate patients, we're just providing a bridge for them. We're not curing them or anything. The critical care team has to give them the correct antibiotics, or if they have organ failure, reduce that, or reverse that situation. So all we do is provide a bridge for the patient while they need that ventilatory and oxygenation support. One of the things, Dr. Ely, he'll be speaking with us tomorrow, but he and his team did a very extensive study. In fact, it went over the course of a year or so. And what they found out is that by giving a lot of the control and the authority to the respiratory therapist and the nurse at the bedside, let them assess the patient and then move on, as opposed to having someone else coming by, okay, this patient's ready, let's go ahead and do that. Or actually they had people that were looking at the weaning off-site in order to give them information about when the patient was ready to wean and all that. But what they did is gave the control to the therapist and the nurse, the feet on the street, so to speak, to where let's do this. And after in-services and training and things of that nature, it got to where the respiratory therapist, 95% of the time, they could accurately assess the patient's condition and did not need additional input or direction from the physicians. So consistency and standard approach are the keys to decreasing the time to extubation. And so this is what we do at Emory Hospital up the street. We do a sedation awakening trial. We do a daily weaning assessment or daily screening, and then we do a spontaneous breathing trial. And we normally run about anywhere from 1,600 to about 2,000 ventilator days a month. And so we have a lot of experience with this. And the majority of our ventilator patients usually come off within a day or so. And we're working to even decrease that even more, especially in our CT units, to where we're graded very heavily on getting that patient extubated and getting them out of the ICU. But we have found just these 3 steps, doing them consistently, everybody on the same page, that we've been able to extubate these patients quite readily. So in summary, the newer modes do offer methods to ventilate the patients in a safer and more comfortable fashion. However, just using some really good common sense that we learned from the ARDS trial, and just using smaller tidal volumes, limiting our plateau pressures to less 30 or less, and the use of PEEP related to the FiO2. Those are just good common sense things that we do, and you don't have to have the world's most progressive ventilator or anything like that. That is basically the operator, the clinician, that decides that. So smaller tidal volumes, plateau pressures of 30 or below, and then the use of the PEEP. And so this way we can guard against barotrauma, volume trauma, and other things that can hurt the patient. So while we're providing that bridge, it is up to us not to do additional harm to this patient. And so, so after an extensive review of the modes, methods, and practices and protocols, basically a standardized approach towards spontaneous breathing is the most efficient method. And in these particular articles, again, it showed in 76 to 81% of the ventilated patients. So you see, again, it's always right around that 75 to 80% range that patients will come off readily in spite of what we do. And it's that other 20% that we really have to focus on. And this is just a list of the references there, and I'm ready for any questions that you might have.